Hey everybody, thanks for joining us. This is Dr. Krista and Dr. Mark from the American Posture Institute, and today we're talking about neurology of pain. We're going to have a lot of fun. It's going to be a really interesting topic that I know is going to benefit so many of you. So we always love at the beginning to see where you guys are from. So we have over 400 people signed up for this webinar. So if you guys can just say, hey, how you doing? Just type your name in the comment box on the side and let us know where you're watching the webinar from. And also, if you're a CPE or a certified posture expert, be sure to let us know that as well. We always love to see, we always have a really cool international group, widespread across the US. So be sure to let us know where you're from and what your name is. And of course, if you're a CPE or a certified posture expert, be sure to type CPE next to your name as well. So today we're going to be talking a lot about pain. And I wanted to, Dr. Mark and I were deciding what the webinar was going to be about. And we said, you know what, let's get in there and talk about pain, because a lot of people are avoiding that pain conversation because they're not confident and certain that they can help their patients overcome pain. So we're going to hit that head on today, and you guys are going to walk away with some really great strategies to help your patients overcome pain instantaneously that visit right away. It's going to be great. You guys are going to love it, I promise. All right, we've got Lorna from Vancouver, Washington. Very cool. I'll be out in Vancouver, Washington actually in a week, speaking at Cairo Fest, so I hope to see you there as well. And Josh from Florence, Montana. MT, I think, is Montana. Been to Montana as well. Guys, as you're just logging in, be sure to let us know where you're from, what your name is. If you're a certified posture expert, type CPE next to your name. We've got Nancy Holman, DC, from St. Charles, Illinois. Very cool. Thanks for joining us, Nancy. Also, if you guys want to give us a shout out on Facebook, let your friends know that you're joining the American Posture Institute for a live webinar. And of course, if you guys haven't already, be sure to give us a like on Facebook. And here's why: because we're constantly putting out more information, such as webinars, blogs, Facebook Lives, free trainings, and you can get all that information straight from our Facebook page. So by giving us a like, in return, we're going to provide you guys with all kinds of value that you can utilize and practice. All right, we've got Ahmad from Hartford, Connecticut. Hey there. John Erickson from Loveland, Colorado. Gianna coming in from Walnut Creek, California, Cairo. Ron Sweeney from Independence, Missouri. Hey, Ron, how you doing? And yeah, Dr. Mark's giving you guys a shout out as well. He's joining us here too. We're actually in Puerto Rico right now. So you're joining us live while we're in Puerto Rico. I'll tell you guys what, it's a beautiful, beautiful country, great place to come visit, come vacation. And Victor from Ireland, and Ireland is another great place to go for a vacation as well. And Patrick with Billings, Montana. Hey there. Hey guys. So kind of a fun thing while we were here in we've got Joanne from Denmark. Hey there. One of the fun things that we've been doing while we were in Puerto Rico, we actually had the opportunity of going over to John Lee Dumas's house. If you guys know him from Entrepreneur on Fire, one of the most successful entrepreneurs in the world, and definitely the most successful podcaster. So we got to stop by and connect with him. You know what was the coolest part is that he loves what we're doing at the American Posture Institute. He has a stand-up desk. He was talking about the importance of posture, obviously for productivity and for being a great entrepreneur. So that's been a lot of fun here in Puerto Rico. Really great to connect with him. We've got Alex from Sacramento, California. We've got Raymond. Hey there. All right, we're going to get started here with the content in just a couple of minutes. But again, as you're logging in, be sure and let us know where you're from. Let us know if you're a certified posture expert. And again, docs, today we're going to be talking about the neurology of pain. And as I mentioned a minute ago, a lot of people are preventing that pain conversation in practice. And here's what we're going to do today. We're going to take pain head on, but we're going to take it from a different perspective than you've probably been introduced to in the past. We're not going segmental. We're talking about pain in the brain, which is actually where pain is perceived. So we'll go through that. Plus, we're going to give you guys some implementable takeaways that you can utilize in practice this afternoon or tomorrow morning that you can help your patients overcome pain right away. Oh, and by the way, happy Halloween, everybody. I forgot it's Halloween. So thanks so much for joining us on your Halloween day. Maybe I should have worn a costume or something more fun, but anyways, it's a trick-or-treat webinar as well. We've got Raymond from Westchester, New York. We've got Tom listening in from Peanut Industries in Pawtucket. I think I've pronounced that correctly, in Rhode Island. Very cool. Ryan from Wisconsin. Very cool. Thanks for joining us here, Ryan. Thanks for joining us, Tom and Raymond. We're glad to have you guys. And with that being said, if you're just logging on, be sure to let us know who you are and where you're from. And we're going to get started. We're going to be talking about pain. All right. Now, as always, guys, if you're watching the first webinar, if this is your first time with the American Posture Institute, we like to keep things really actionable and give you guys application. So we're going to go through some really good pain protocols that you can utilize at the end of the webinar. If during the webinar you have any questions, be sure to type them along the side. If I miss them, because I'm kind of in the moment, I'm giving you guys information, then don't worry, I will definitely get to it at the end. So we'll do a live Q&A at the end. If there's anything that you thought, oh, I didn't really quite get what she was saying, don't worry, we're going to answer all those questions, because my goal is that you walk away from this webinar going, I completely understand the neurology of pain, and I have a strategy to help my patients overcome pain right away on that visit. So that's the goal. That's what we're going to learn today. So if you have any questions, type them in the side. If I skip over it, if I miss it, don't worry, we'll get to it at the end. Just type it again at the end when I open it up for live Q&A. Sound good? All right, here we go. Okay, also we have Yvonne joining us from California, Mohammed from the UK, and we've got Tom who says, thanks for the education, Drs. Mark and Krista. Tom, you're so welcome. Thank you for being proactive and joining us on the live webinar. We appreciate you. Okay, so we're talking about the neurology of pain today on this webinar. And here's what I want to I want to confront this first off, right out of the gate. A lot of practice management companies, a lot of people out there are saying, don't talk about pain with your patients. I understand from their perspective why they're saying don't talk about pain with your patients, because they're not really clear necessarily on how to get patients out of pain. So when we understand the neurology of pain, we can take pain head on, and we can understand our patients at a different level, for one, and we can meet their value system. Because for so many people, the reason that their patients came in the door was because they had pain or they had a problem. So by recognizing that pain is most commonly the number one need of your patients in terms of getting well, maybe it's the reason they actually, came into your office, in your door, recognize that and don't discount it, because to the patient, that is most likely their most common thing that is the most important to them. Okay. So by acknowledging that, one, it's taking you in the right direction where you're meeting the patient where they're at. Two, we can actually get them out of pain when we understand the neurology of pain. And then three, we can extend the conversation. So the patient's out of pain after a couple of visits, but then we're going to go through complete brain-based postural correction care with that patient as well. So it doesn't end at pain. That's just the beginning. But when we can get the patient out of pain, they're going to have a better response to your brain-based postural correction care. So take pain head on. Don't shy away from it. Don't ignore it with your patient. Take it head on, get the patient out of pain, and then get them more functional results with brain-based postural correction care. Because the second that they're out of pain, they're going to have better progression once we really get into that rehabilitation. Cool? So today, I just wanted to share with you guys some statistics. So in terms of having high value to your practice, there's 100 million Americans who are suffering from chronic pain, 100 million. Now, if we compare that statistic to other chronic diseases such as diabetes, that came in second, there's 25 million patients in America suffering from diabetes. Yes, that's a lot, but in comparison to pain, it's only a quarter of the amount. So patients are presenting with chronic pain. It's the number one factor leading patients into offices, into all healthcare offices, whether it's a medical doctor, a chiropractor, osteopath, physical therapist, whatever you do, that's what's driving patients into your office. So don't ignore it. 100 million patients need a doctor who can take pain head on. And we all know that a natural approach to taking care of pain is going to be so much more beneficial for the patient, because we're actually correcting the pain. So 100 million Americans have pain. What does that mean in terms of finances? It means that it's $635 billion market in America. $635 billion per year is spent on taking care of musculoskeletal pain. It's a massive industry. And here's the deal. We can really help patients because so many people are suffering from chronic pain. So we're going to take this head on. You guys are going to learn that pain is in the brain. It's perceived in the brain. We're going to learn why this is really commonly misunderstood from our formal education, and then clear that gap and make that connection for you guys. We're going to understand that pain is an output of the brain. It's actually an action signal. So when the brain feels as though it's being threatened or there's risk, then we have a pain output signal to take action to prevent neuro overload, which we'll explain. And then finally, we're going to go through a really great protocol you guys are going to love. So it all begins then with the Pain Neuromatrix theory. So Pain Neuromatrix theory came out in about 2003, so it's a fairly new concept. Now, if you guys are going, well, what about the gate control theory of pain? That came out in I think 1965 by Melzack and Wall. So 1965, we have a theory that says that we have ascending pain signals, and they arrive to the brain and are perceived as a noxious stimuli. Now, that is absolutely still correct, but what we're seeing from 1965 to 2003 is that there's been an advancement in our understanding of pain. So the gate control theory said that if I have pain if I have dysfunction in my wrist, then those pain receptors are going to be activated and sent to my brain and understood as a noxious stimuli. Again, correct. Yes, and we have more information now showing that when a patient experiences pain, that multiple areas throughout their brain are igniting or activating in response to that pain pathway. So it's no longer just about the noxious stimuli arriving in the brain, it's how the brain perceives that pain. And something that's really interesting too to understand is that pain is not necessarily related to degeneration. I know you guys are seeing this in practice. I think there's 83% of patients who have a herniated disc actually don't feel pain. And they did another research study with MRIs where they did MRIs of knees, and so many patients presented with torn meniscus and they couldn't actually feel it. They weren't expressing pain. So recognize that degeneration and dysfunction are something we'd absolutely want to correct, but it's not necessarily related with pain pathways because, again, pain is not segmental. So let's talk more about that. So what are the areas that are activated within the brain when we have a painful stimuli? When the patient experiences pain, what is happening within their brain? Well, we have what's called the anterior cingulate. So that's going to be the part of the brain in the limbic system. You guys know what the limbic system is, right? The limbic system is going to be your emotional center. So that area is being ignited with pain. And of course, that produces that emotional aspect of pain that patients are experiencing. Something that's important to understand is that pain and suffering, although commonly put together in words, are not synonymous. So pain is the experience of a noxious stimuli, but suffering is our response, our emotional response to that pain stimuli. So pain and suffering are not the same thing. They're commonly used together synonymously with your patients, but they're not the same thing. And that's because the reason there's so much suffering associated with pain is because of that limbic response. The limbic system is being ignited with activation when the patient is in pain. So recognize that pain and suffering are not synonymous, but the patient is likely going to be suffering when they do have pain. And that's because of that aspect in the brain. And then also the insular cortex is going to activate as well. So what's the insula? The insula is in charge of interoception. Now, interoception is just a big word for how we perceive the inside of our body. So for example, a lot of patients also experience sickness when they're in pain. So if you guys have ever had this experience yourself or you've heard it, maybe in a textbook even, when a patient has a fracture. So if you've broken your wrist, for example, and I've done this myself and I can tell you exactly how it felt. I broke my wrist. I had that initial shock and initial amount of pain. But then as I was going home, I started feeling very nauseous as well. So that's going to be interoception. The insula created that experience within my pain pathway. So I experienced pain because I had this, broken bone. But in addition to that, my brain ignited the insular cortex, which is in charge of interoception. And so I experienced nausea in relation to that pain pattern. And I was also emotional as well. I was crying not just because I was in pain with that fracture in my wrist, but in addition to that, I was emotionally connected to the experience. So again, pain is not just about a noxious stimuli. Pain, again, is activating the limbic system, the anterior cingulate, and the insular cortex, which is interoception, which is how we perceive pain and how we perceive our organs, which is why I had that nauseous feeling. And a lot of your patients are going to tell you the same thing. So also the thalamus is going to be activated. Now the thalamus is what's called the relay center. So we have a billion messages constantly coming in to our brains every single day. By watching this webinar, for example, you're getting a lot of visual messages. Now what the thalamus does is it decides what's important. And what's important, it then sends to the higher levels of the brain, more specifically the sensory cortex. So when you have that pain pathway that the brain sees as important, it decides decides that it's important in the thalamus. So you're constantly receiving different stimuli, whether it's noxious pain stimuli or whether it's visual or auditory or all these different things. But your thalamus then says, hey, brain, we need to pay attention to this. And then, of course, the sensory cortex. So, sensory cortex is going to be in your parietal lobe. And the sensory cortex is how we perceive our world, it's all sensation. So that noxious stimuli then is going to be the perception of how your brain feels it within that sensory cortex. Also recognize, guys, that within that sensory cortex, we have what's called the sensory homunculus. That's going to be a cortical map. So your sensory homunculus, if you guys remember those pictures from your neurology textbooks, right? It's a picture like this, and it has all the different parts of the body within that representation. Now, the parts of the body that have the most innervation, specifically cutaneous innervation, are going to have a larger representation on that sensory homunculus. Now, when you have an injured area, and for example, you stop moving it, then it's going to tell the sensory cortex that this part of the body is no longer important. So the worst thing that we can do if you have a pain, if you have an injury, for example, that creates pain, the brain pays attention to the pain. But in addition to that, if you wrap up, a knee, if you sprained an ankle or you're hurting a knee and you wrap it up and put it in a brace and you can move it for 6 months, then the brain stops seeing it as being important. And that sensory homunculus, which is a cortical map, a cortical representation of all sensation of your body, is going to start blurring together and eliminating that area where the pain was originally present. So recognize that the sensory homunculus, the sensory cortex within the parietal lobe, is very important for your perception of pain within the brain, okay? And one of the worst things we can do is just not move the area of pain. And you guys know exactly what I'm talking about, because what's the first thing you do if you touch a hot stove, for example? First, you withdraw, and second, you start shaking your hand right away. Why? Because we want to overcome that pain by moving that area. And when you move it, you're making it more important for the brain. You're making the movement, which is a positive stimuli to the brain, it's proprioception, more important. So that's going to be why we need to move what we need to move when we're in pain, not just be sedentary or not just wrap everything up in a brace and call it good and send the patient out the door. Okay, so we're talking about Moseley's pain neuromatrix theory then. And what we've just discovered is that when we have a painful experience, it's perceived in the brain, it ignites multiple different areas of the brain, again, the anterior cingulate, the insular cortex, the thalamus, and the sensory homunculus, or the sensory lobe, the sensory cortex within the parietal lobe. Now, pain then is going to be only activated when there's enough risk to the system that the patient experiences what's called neuro overload. Neuro overload is that threshold point where there's enough stimuli coming in, enough stress to the body that the brain then expresses a pain pathway. It expresses that perceived pain. I don't know if you guys have noticed, but maybe with yourself or with your patients, but patients tend to come in having the same pain areas. So for example, somebody who has lower back pain on the right side, they've always had that lower back pain on the right side. Why is that? Because with the pain neuromatrix, multiple areas of your brain are igniting with pain pathways. It's easier with chronic pain that when your body is to the point of neuro overload and it's going to send out a pain signal as an action signal to warn your body to make a change, when it's going to send out that pain action signal, it's easier for the brain to go back to an old pathway that's already been created, which is why your patients are feeling better for a while. They're like, yeah, that back pain I always had on the right side of my body, it's a lot better. And then, something happens within their life where they get to that point of neuro overload. It took them over that threshold, and the brain sends out a pain signal. It's an action signal, again, to make a change to reduce the stress and the risk to the system. Now, it goes back to that same amount of pain. So maybe they did nothing traumatic to their lower right, the lower right back, but that's where they sense the pain again because the brain already has stored that chronic pain pathway. And so it's easier to reignite that pathway as a warning signal to the body, an action output to make changes, than creating a whole new neural output signal. Okay, so chronic pain, then remember, is going to be that your patients are going to commonly feel pain in the same area, not necessarily because of the level of degeneration in that area, but because the brain already has created that neural pathway. And so when they get to the point of neural overload, the brain says, okay, we need to make a change here. We're to neural overload. So I'm going to send out an action signal, which is a pain signal to the body so that the person makes a change, so that I make a change, right? And when we do that, it's most commonly, not always, but most commonly in a lot of patients, going to be that same pathway that they've had for maybe since they were 10 years old, right? Yeah, my lower back pain, I always have lower back pain on the right. It never goes away. Maybe it'll go away for a couple days, but then it comes back. Well, that's because the pain signal is being ignited, the same pain signal over and over and over again, because it's easier for your brain to do. Your brain is conserving energy. So it conserves energy when it ignites that same pathway. Another important takeaway from what Mosley is telling us with the pain neuromatrix theory is this: that modern day practitioners should understand that pain is an output signal of the brain. It's not necessarily because of an injury at a segmental level. Okay, pain is in the brain. And when we recognize that as modern day practitioners, then we can understand how to help our patients get out of pain, overcome pain, and prevent more pain from happening. And again, when they do that, then we can focus on getting their posture corrected as well. Okay, so pain literally changes your brain. So we talked about that when a pathway becomes chronic, it stays in your brain and it reignites. Also, we have changes within that sensory homunculus and then changes within the motor homunculus. So your brain, your cortical maps within your brain blur together based upon pain and lack of movement, lack of stimulation. So recognize that your brain is physically changing in response to pain. Neuroplasticity, again, our brains are dynamic. They're constantly changing. We can have positive neuroplasticity and we can have negative neuroplasticity, meaning that the brain's always changing based upon what's the most important thing. And it's going to be a negative sense of the term neuroplasticity when we have pain and degeneration that creates changes in the sensory homunculus and the motor homunculus to have a blurred mapping. Okay, that's going to be a negative consequence. And we can again prevent that by getting rid of that pain for your patients. So let's talk about an important study that was done by the Institute of Medicine. And what they found is they found the following things with their patients. I'm just going to read you guys these statistics because it's very profound to our understanding. So the first thing was control over chronic pain. 51% of patients that participated in this survey felt that they had no control over their pain. So more than half of the people felt like they had no control of their pain. 60% said that they experienced breakthrough pain more than once daily. So 60% of the American population experiences really bad pain more than one time per day. Okay, that's significant, right? And then the impact on quality of life. 59% reported an impact on an overall enjoyment of life. So more than half the people out there are suffering, suffering again being how they respond to their pain. They're allowing it to affect their quality of life. 77% reported feeling depressed. They feel depressed because changes are happening in the brain. We'll talk more about that here in a second. 70% said they have trouble concentrating. 74% said their energy level is impacted by their pain. 86% reported an inability to sleep well at night. Let's talk about a few of these things. So 77% of patients feel depressed when they're in chronic pain. The reason they feel depressed is because, our decision making, our humanness all happens within the frontal lobe. When we're igniting our brain with pain signals, then we're not focusing on what makes us human. And they're going to have a sensory disassociation. They're going to lack empathy and motivation and feel depressed. They're going to stop moving. And of course, stopping movement is a vicious cycle, because then we're going to have blurring of the cortical maps, which eventually is going to lead to more pain output, more action signals of the brain. Again, pain is an action signal down to the body saying, make a change. 70% had trouble concentrating. So we talked about with the thalamus. So the thalamus is the relay center, meaning that all of the stimulus that we receive in our world is all sent to the thalamus first before being sent to the higher order parts of the brain for processing. So the thalamus says, pain's important, pain's important, pain's important. So of course the patient can't concentrate because they're focused on the pain. Their thalamus, their neurology is making them focus on their pain. They can't overcome that. So, they can overcome it when we do the proper strategies. But if they're just sitting there in pain, they're having that inability to concentrate because of that reason right there. And then 86% report an inability to sleep well at night. So an inability to sleep well, again, it's going to be that thalamus. So we have different types of neurons within the thalamus. And one of the types of neurons is going to be active at night when we're sleeping. Okay, so it's active at night. And because we have less stimuli while we're sleeping, the thalamus then relies on those neurons and it says, there's pain happening. So it activates in the middle of the night. And then your reticular activating system, which is in your brainstem, sends a signal to your brain or to your higher order processing of that brain that says, be alert, be alert, be alert, we have pain. That's why you wake up in the middle of the night going, oh my God, my knee hurts, or you have those night sweats, or why you have that pain in the middle of the night specifically, because there are neurons dedicated to that in the thalamus that wake you up at night because now your pain is more important again. Okay, so that's why these patients are experiencing this. And again, we understand the neurology. It just makes sense. So in addition to that, let's talk kind of more from a receptor level. So pain is in the brain, it's perceived in the brain, but there are sensory receptors that carry that information there. So we have what's called superficial pain and we have deep pain. Superficial pain is going to be the prefactor, it's going to happen first, and then we have deep pain. So that superficial pain is going to be carried by A delta and C fibers. Now these are actually slower fibers than your typical, like if you do an adjustment of the spine, for example, that's going to activate much faster, more myelinated pathways. Pain is actually a slower pathway. So if you have that superficial pain, that's going to be your initial withdrawal. It's going to be that quick reflex that we need to withdraw from something that's causing noxious stimuli or causing pain. In addition to that, I talked about it before, you're going to get the counter-irritant theory, which says that movement is going to be really important. So you touch a hot stimulus or you stub your toe at night, stubbing your toe at night is like the most painful thing, right? So what do? You instantly grab your toe and you start rubbing it, or you start shaking your foot because it feels better because we're overriding that pain stimulus. So that's going to be your superficial pain. That happens instantaneously with pain. But then in addition to that, we have what's called deep pain. So deep pain arrives after the superficial pain. And this is where we actually end up creating whole postural distortion patterns around our pain. So you'll see patients that then come in with an antalgia. Okay, they didn't have an antalgia as their first response to pain, but they developed an antalgia, that postural distortion pattern around the pain pathway. Or you see them limping. So if you sprain your ankle, the initial pain that you have is going to be really sharp. It's going to stop you instantly. You're even going to fall to the ground. But then you're going to get that deep pain sensation where you're going, I'm not putting any weight on that ankle. And that's, again, creating a whole postural presentation, postural distortion patterns around that pain. So that happens from the deep pain. Now, the pathway that carries pain to the brain is going to be the spinal thalamic tract. And so we start with a receptor at the end organ. So maybe if you stubbed your toe, that's going to be the receptor. It's going to cross instantaneously in the cord. It's going to ascend up to the thalamus and then over to the sensory cortex. So that's how pain actually arrives to your brain, how noxious stimuli arrive to your brain. And then again, the brain decides if it's important, and the brain perceives neural overload, and is going to create an output signal of pain in order to make changes. Okay, so another important thing to understand about pain before we move into actually some treatment protocols is that pain is very commonly misunderstood or misdiagnosed. Allow me to explain a little bit further. So a lot of pain, for example, can actually be visceral pain, meaning that there's dysfunction happening within the organs. And because we can't feel our organs, I mean, literally, like try and feel your kidneys right now or try and feel your liver. None of us can do it, right? So when there's, again, pain is an action signal. So it's saying that there's neural overload and there's threat to the body. So when there's that risk, when there's dysfunction within the viscera, then it creates a pain signal at a cutaneous level. So for example, you don't have liver and gallbladder pain at the level of the liver and gallbladder. It actually, we have a referral pain pattern, which is going to be to that right shoulder, whereas the left shoulder could be the diaphragm and the lungs, the stomach could be the thoracic. So recognize that when patients come in and say, I have pain here, we can't just think too segmentally. We need to understand what's really happening within their physiology, okay? Second thing that can be misconceiving when a patient comes in with pain So when you're doing your sensory tests, when you say, does this feel the same as this? Does this feel the same as this? And you're testing vibration, 2-point discrimination, you're testing all the light, touch, pain and temperature, you're testing these things with your patient. And the patient's really hyperactive. They have a hyperactive response. That's going to be transneuronal degeneration. So transneuronal degeneration, I'm going to call it TND because it's a mouthful if you guys are okay with that. So TND then is going to be hyperactivity of neurons. How does that really make sense? A lot of people think, well, it's about to die. There's degeneration. Wouldn't it be a lower activity of the neuron? And here's the deal. The brain, neurons within the brain need three things. They need oxygen, they need glucose, and they need activation. So right before a neuron dies, because it's become so degenerated to the point of dying, it seeks activation. So it lowers its threshold so that it can be activated instantaneously. It can be activated right away, easily. Okay. So the threshold then has changed of that neuron that has been degenerated and about to die. And so there's hyperactivity response of the patient. So the patient says, yes, I can feel that stimulus. You may think, okay, there's no dysfunction in that area, but recognize that it could be transneuronal degeneration, or TND, which is creating that misunderstood pain pathway. Okay. So think about, patients that present with tinnitus, with the ringing of the ears. There's no ringing actually happening in the sense that there's not bells that are making that ringing sound, but TND neurons that are about to die, they crave activation. So they create a response as an activation to that perceived stimulus. Or fibromyalgia patients. These are going to be really hypersensitive patients that have that fibromyalgia type of pain, which is going to be diffuse pain. It's going to be really hypersensitive. That's going to be another example of neurons that are seeking activation. So they're hypersensitive or hyperactive. Okay, important understanding there. And then now I want to make a correlation for you guys about posture and pain. So, of course, at the American Posture Institute, we love to talk about posture, but let's actually talk. We don't always talk about it in relation to pain. We're going to do that today. So, you have what's called the pontomedullary reticular formation in your brainstem. Okay, now that's a big word too, but basically what that means is where the pons and the medulla are within the brainstem. That's your powerhouse of your posture. That controls your postural design. It controls your ability to inhibit flexion. So also within that same area, the PMRF is descending pain inhibition, meaning that it reduces the amount of pain. So if the PMRF within the brainstem is not functioning properly, your patients are going to present with more pain and they're going to present with postural distortion patterns. There's a direct correlation right there. So then to change the PMRF, we're going to do the same strategies that we do with postural correction, because when we stimulate the PMRF, we know that we're going to have better ability to inhibit flexion, which creates that upright extended postural design that we want, okay, for our patients. So by activating the brainstem or the PMRF, not only are we having better posture, better postural outcomes, but we're also doing descending inhibition of pain. So that's going to be so important within your clinics to focus on postural correction also from a pain perspective. It's going to highly benefit your patients, okay? All right, so just kind of some clinical takeaways. Don't overlook transneuronal degeneration, TND. When you're doing your testing, I forgot to mention this as well. When you're doing your testing with your patients, test for endurance. So again, the neuron's going to fire because it's craving activation, but it can't hold that firing pattern for very long. It's going to fatigue very quickly. So that's how you can tell the difference between a TND neuron and a healthy neuron. So again, with TND, there's going to be activation, but it's going to have high fatigability, meaning it can't hold that activation for very long. Versus a healthy neuron, it's going to fire and it's going to be able to maintain that firing pattern. Okay, so don't let TND confuse you if the patient has dysfunction or not. Look for hypersensitivity with these patients. Also recognize that visceral pain could be confused for musculoskeletal issues. So that's going to be a little bit, beyond this course and beyond the webinar, but you can consider doing visceral fascia work. You can also consider looking at their diet, okay, whatever works with the flow of your clinic. Recognize that the PMRF within the brainstem controls posture. It also controls pain. So descending pain pathways to inhibit are going to be from that brainstem. Okay, and then again, pain is an output of the brain, it's perceived in the brain. So now let's talk about how some strategies to overcome pain. So I want to present to you guys what's called the opposing joint theory. Now, the opposing joint theory, let me explain it first before we kind of put it into action. So while standing, for example, if I'm to do a gait pattern or just standing statically, we have what's called the force transfer effect. So force transfer comes up from my right foot, for example, and it's going to cross over to my left SI joint and ascend ipsilaterally. So that means that the upper half of my body and the lower half of my body are connected through that transfer of force in kind of an X pattern. X pattern. Okay, so my right upper limb and my left lower limb are connected. My left upper limb and my right lower leg are going to be connected. So recognize that that's how force is transferred through our body. So if we understand that that's how force is transferred through our body, then it makes sense that if there's dysfunction in a joint in my right lower limb, that there could also be dysfunction in the opposite upper limb, also with postural distortion patterns. So we could call them postural compensation patterns when, for example, there's a right high hip and a left high shoulder. That's going to be that transfer force right there. So we're going to create postural distortion patterns around the force of transfer that's happening in an X factor. Okay, so it's going to be cross chord pattern, just like a cross crawl effect, right? And we're going to have compensatory postural distortion patterns. So literally while standing or while doing a gait pattern, this is why gait is so important, first of all, to have proper gait, but you're literally having force that transfers from your foot up to the opposite TMJ. That's how far the force goes. So recognize that's happening with your patients. And a really good way to help your patients get out of pain is what's called the opposing joints theory. So I just told you that the right lower limb and the left upper limb are connected and vice versa. So more specifically, which joints of the upper and lower limbs are connected? So we have the phalanges and the phalanges, meaning the fingers and the toes. We have the ankles and the wrists, the knees and the elbows, the hips and the shoulders. Those are going to be for our limbs. And then for the thorax or for the spine, we have the hips and the shoulders, but we also have the pelvis and the cervical spine, the thoracic spine and the lumbar spine, and then the TMJ and the coccyx. Okay, so recognize that functionally and neurologically, these areas are connected with one another. Okay, and when you have that transfer of force that's affecting one of these joints, more than likely it's going to be affecting the opposite joint or the opposing joint. And a great way of helping them overcome pain is by activating that opposing joint. Make sense? So, for example, and how you want to activate it, first of all. So, if you have pain, if you have knee pain and flexion, okay, I told you that the knee is then related to the opposite elbow. So, right knee pain and flexion, then I'm thinking I want to work with the opposite upper elbow. Okay, so if I have pain and flexion, then I want to extend my elbow. I want to do exercises or manipulation of that joint that take it into extension. Okay, so again, I have right knee pain and flexion. So the opposing joint that's connected is going to be the opposite, the left elbow. And if I have pain and flexion, then I want to extend that joint. So I can do a manipulation of the elbow to help the right knee, or I can do exercises that are gonna, you can do figure eights, for example, that are gonna be moving that joint into extension. Okay, so let's give a couple more examples. So also something that's important before I say that is with the spine. So how the transfer pattern works is that the limbs are going to be contralateral, but the spine itself is going to be ipsilateral. Okay, so if I have pain on the right side of my neck, the patient has pain on the right side of the neck, then we're talking about the right pelvis. Or on the right side of the thoracic spine, we're talking about the right side of the lumbar spine. Okay, so limbs are going to be contralateral. The spine itself then is going to be ipsilateral, and that's because that's how the transfer of force happens while standing. Okay, so or while doing a gait pattern. So if we do some more examples then we know that if the patient has pain with right cervical rotation, what's going to be the opposing joint theory that's going to help them overcome pain. If I have right cervical rotation that causes pain, then looking at the pelvic area, I want to do left rotation. So I'm going to do the opposite movement, but on the same side of the body. Okay. Or if I have, we went through knee flexion. So if we have right ankle pronation, if I have pain when I pronate my right ankle, what's going to be the opposing joint? We're going to have left wrist supination that is going to be therapeutic. Does that make sense? So the ankle and the wrist are connected. Okay. The ankle and the wrist are connected. And if I have pain with pronation, then I want to supinate the opposing joint. All right. Or if I have pain on thoracic flexion, then the opposing movement is going to be lumbar extension. So thoracic is going to be ipsilateral, but I'm going to do the opposing movement. So if I have pain with flexion, which is so common for our patients, that's why I brought this example, then we want to do lumbar extension. It's going to help them have better range of motion than in that thoracic spine. Okay. And also think about this with postural distortion patterns. So if I'm correcting the right hip, if I have a right pelvic postural distortion pattern, then think about the left shoulder. Think about, so the right hip is going to be opposite. So right hip and left shoulder. Think about those compensatory postural distortion patterns that can arise because of those opposing joint theories. Okay. So hopefully that's making sense for you guys so far. I am going to open it up for questions. So if there was something that you missed there, no worries. But I want to give you guys those examples because it's so simple to do. So again, recognize when you're doing your examination, how do they feel pain and where do they feel pain? So right knee inflection, okay? So left elbow extension. And you can have the patient do, even outside of the office, give them exercises that they can do that promote extension of that elbow. So that's going to be the cross cord patterning that's going to eliminate pain for that area. And it's going to be instantaneous. You'll have your patient do it in the office first, and they're going to go, wow, doc, I feel so much better. Thanks. I had no idea. And then, of course, they want to keep doing that outside of the office as well. All right, so today, okay, it looks like there's some questions. Give me just a second here. Let me just turn to those. Okay. So before we go into the live Q&A, I just wanted to conclude by saying this, just a reminder that pain is in the brain. It's perceived in the brain. And so when we understand that as practitioners, and we understand that pain is not necessarily where the patient points to and says, hey, doc, I have pain here. That's not necessarily how we want to follow our treatment plan because they told us they have pain in a certain area. What we want to do is recognize that means a lot to the patient, but then recognize that it's in the brain. And we need to make neuroplastic changes in the brain through postural neurology in order to help them overcome those chronic pain patterns. Because if not, it's going to keep coming back. Pain is an output from the brain. It's going to be an action signal to make changes. So recognizing that, then I wanted to invite you guys to also take advantage of another opportunity. So we're releasing what's called a free postural neurology training. So in postural neurology, we're helping you make those connections, the connections that were never made in school for us, right? So it's going to be the connections between the brain and the posture system. So you're going to learn in this free training, you're going to learn more about digital dementia, which is modern day health epidemic. You're going to learn the eye spine vestibular model of correction. Plus, you're going to learn how to do the neuroscan. So the neuroscan is how you can analyze brain function in relation to the posture system in 3 minutes or less. So we're already about to go over time on this webinar just talking about pain. That's why I wanted to invite you guys to take advantage of this free training. And Dr. Mark's going to post the link to this free training in the comments below. So I hope you guys take advantage of that and you can learn more about postural neurology and more strategies to help your patients overcome pain in their office, in your office. All right, so it looks like we already have some questions already. So we have says, can you talk about any connections between sleep, anxiety, and thalamic action? Does anxiety have any similar presentations to pain in the thalamus? That's a great question. Thank you for answering thank you for asking. And the answer is yes. That is the connection. So we have what's called the reticular activating pathway, and that's actually going to be ascending directly to the thalamus. So your reticular activating system then is what makes you alert and paying attention. So when you're sleeping, obviously you're not in a state of alertness. But when you have that anxiety or you have those pain pathways, then that reticular activating system is going to be active, and it's going to go to the thalamus that says, hey, thalamus, this is really important. I want you to wake up the brain. And that's when the patient's going to have that problem sleeping at night, or they're going to wake up in pain, or they're going to wake up in anxiety. So that's that direct connection. So I appreciate you asking that question. That's a really good connection that I didn't make for you. So thank you for bringing that up. Okay, sorry, I'm just going through these comments. It looks like you guys were really active during the webinar. I get talking and I just, I could talk all day. So Yvonne says, will you address pain and inflammation as with autoimmune diseases? And then autoimmune disease related to pain seems to be really hard to treat without medication. Yeah, so inflammation. Um, inflammation is it is, Yvonne, that's a really complex question. And autoimmune disease is going to be a really complex case presentation. So with postural neurology, we don't actually go into nutrition. That's going to be beyond the scope of our courses at the American Posture Institute, but definitely looking into that anti-inflammatory diets and looking into how you can reduce inflammation associated with autoimmune is going to be extremely beneficial for your patients. I'm not necessarily the person to ask for recommendations for nutrition, but what I can say from a postural neurology perspective is that you can help overcome those pain pathways by moving the joints more often in complex ways. So, for example, the brain craves complexity. So when you move your body in complex ways, then it's going to stimulate the brain to create positive neuroplasticity for those areas where the patient is experiencing pain. So to at least prevent for a while anyway, having the patient do medication, then you can at least try these strategies first, recognizing that autoimmune patients are going to be absolutely very, very complex. And don't put aside how they're associating that suffering with the pain. But if we can overcome those pain pathways by stimulating the brain in a positive way, they're going to have less action signals or output signals from the brain in terms of pain, which is going to help them overcome the anxiety and the depression that's commonly associated with autoimmune diseases. So recognize that, try out those things first, and then see if you need to go in from a nutritional aspect as well. Okay. Yep. Tom says Dr. Andrea Wool is putting out great stuff, autoimmune, absolutely. So that's important to look into as well. Let's see, do you guys have any other questions? I'm just kind of going through the comments here. Okay. So again, regarding the free training that I was just mentioning regarding postural neurology, if you guys want to dive deeper into neurology and how you can implement it within your clinics, then the free training that I'm inviting you guys to actually goes live on Wednesday. But because you joined us on the webinar, what you can do is actually get a sneak peek at it. So I believe Dr. Mark posted the link and you guys can access it immediately, which is really cool. So that's just for our webinar listeners. It actually goes live on Wednesday, but you guys are the action takers, so we want to give you that instant access. All right, Amber says, can you give another example? Okay, so for left side lower back pain during standing, sitting, and extension, would the thoracic spine into flexion on the same side be the therapeutic movement posturally? Just want to make sure that I have that correct. So let's see, we're saying left side low back pain, so left side lumbar pain, we're assuming, okay? Let's see, when the patient's in extension, would the thoracic spine into flexion on the same side? Amber, you nailed it. That's exactly what you want to do. So again, with the spine, it's going to be an ipsilateral correlation. So just as Amber mentioned, if I have pain on the left side of the spine, specifically with the lumbar spine, then we want to activate doing the opposite movement of the thoracic spine. So the lumbar and the thoracic spine are connected with the opposing joint theory, and because of the transfer of load, how that occurs. So the thoracic and the lumbar spine are definitely connected, just like Amber said, and the patient is experiencing pain on extension of the lumbar spine, so we can do flexion of the thoracic spine. Absolutely. So you can do a lot of different movements with that. What we don't want is the patient thinking that they can stay in flexion all day long of the thoracic spine. That's not what we're intending. But you can do movements, for example, like movements like this where they're gliding the joints of the thoracic spine. You can also do them to the side. That's going to be beneficial specifically for that thoracic spine. Yeah, stretching is going to be beneficial as well. So again, I'm glad Amber mentioned that, because with flexion of the spine in general, especially the thoracic spine, recognize that from a treatment protocol to get rid of their pain, we can definitely do that. But we don't want the patient sitting in flexion all day, because they're going to then develop poor postural habits, poor postural patterns. So that's a really good question that Amber mentioned. All right, guys, if you have any more questions, feel free to type them in the side over here. I'm more than happy to answer any questions you guys have, because I know I covered a lot of information. And like I said, I always want you guys to walk away with practical application from our webinars. So anytime that we're getting on the phone together, we're getting on this webinar together, I want you to walk away saying, okay, that makes sense for this patient that I've been wondering about, or I totally understand how I can apply this with the other patient. So by having that connection, I want you guys to walk away with that connection, so that it's clear. So again, if you have any questions, if you need to get anything clear in your mind, just like Amber just asked or Yvonne just asked, be sure to let me know. And again, I want to invite and encourage you guys to take advantage of the free training on postural neurology. So postural neurology is just so exciting, because you know what? Docs, every single patient who walks into your office is a neurologic patient. So by understanding the neurology of the posture system, you expand your opportunities, you expand your ability to help patients so much more from a whole different level, a whole different perspective. Again, postural neurology puts together those connections. So if you guys were anything like me in neuroanatomy class, you spend hours just memorizing tracks and memorizing this part of the brain and that part of the brain, but there was never that connection of how it related to posture and postural design and how it related to function. So we're going to put those connections together for you guys with postural neurology, because it's so important to make those connections and understand it. And when you do, you're going to start seeing your patients in a whole different way, a whole different manner, and you can help them. You can help them get out of pain. You can help them have proper posture. You can help them function better. You can have them have these optimal postural designs in a way that's going to help them live a better life, because at the end of the day, that's the most important thing for the patient. All right. Lorna says, thanks for the new connections. Joe says, thanks, docs. You guys rock. Great insight and refresher. Hey, you rock too. Thanks for joining us. Mohammed says, one more example of hip joint pain, please. Okay, cool. Thanks for asking that. So hip joints. So the hip joint is going to be correlated with the contralateral shoulder. So you didn't give a specific side. So we're going to say right hip joint. Does that work? So right hip joint, pain in flexion. My right hip joint has pain and flexion, so I want to recognize the connection with the opposite shoulder. So we're going to target the left shoulder. So we're going to do exercises that promote extension of the left shoulder, so bringing it outward versus bringing it inward. Okay, so again, right hip pain during flexion, then we're going to stimulate the left shoulder to promote extension. Cool. Does that make sense, Mohammed? Does that clear that up for you? Now, do make the difference between the distinction in your mind between the hip joint and the pelvis. So the hip joint is going to be the contralateral shoulder, whereas the pelvis is going to be the ipsilateral side of the cervical spine. Okay, so make that distinction, because if I just say hips without making that clear for you guys, you might think hips in terms of the entire pelvis, but we're talking specifically hip joint, contralateral shoulder, pelvis, same side cervical spine. Okay, hope that makes sense. Mohammed, if you have any other questions, be sure to let us know. That goes the same for everybody else. We really appreciate you joining us on this live webinar today. As always, we say at the American Posture Institute that your success is our priority. So if anything comes up when you're working with your patients this week, when you implement this stuff, be sure to let us know. Let us know if we can help you. Of course, be sure to check out that free training that we're just releasing on Wednesday. It goes live to everybody else on Wednesday, but you guys, because you joined us for this webinar, are going to get a sneak peek. So take advantage of that. If you have any questions along the way, be sure to let us know. We've actually set up a whole Facebook group around this new postural neurology free training. So be sure to take action, join us in the Facebook group. We're going to keep you guys in the know, because you're the proactive ones joining us for the webinar. All right, looks like no more questions, so we're going to wrap it up there. Make it a great day, docs, and remember, it's posture by design, not by circumstance.